Good afternoon or good morning, depending where you are in the country. We'll be starting in just a moment as folks are logging on. Thank you. Okay, we're going to go ahead and kick off. So I want to start on behalf of Cope Health Solutions and our speakers today by welcoming you all to our webinar. Today's focus is ensuring long-term sustainability of your telehealth and remote patient monitoring strategy, a topic that is timely with everything that's happening today. So I'm going to walk through a couple of introductory slides, the agenda, some key points for consideration, and then hand it off to our speakers. So next slide, please. So today, I'm Alan Miller, CEO of Cope Health Solutions, very happy to be able to facilitate this webinar. We've got Dr. Andy Snyder, who is a Principal and Chief Medical Officer with Cope Health Solutions. Andy has very deep experience developing clinical strategy for population health and clinically integrated networks and IPAs across the country. Founded and built a CIN in New York, was one of the early builders of IPA that took risk in the Bay Area of California, and just a national leader in thinking about clinical models and of course now how telehealth is integrated into that. Rhonda Hefton, really excited to have Rhonda with us as well, registered nurse, very experienced executive. She's one of our vice presidents at Cope Health Solutions and has also extensive experience building and implemented value-based care and physician alignment strategies. Rhonda actually is currently working with us to manage and drive the population health infrastructure and value-based payment for a large medical group and IPA in New Jersey. She's worked with Pioneer and MSSP ACOs, worked across the continuum. Really pleasure to have Rhonda with us. And finally, Bob Blair, who we are extremely pleased and appreciative and really honored to be with today. Bob is one of the most experienced medical group leaders in the country and in Kaiser, and he's the Chief Administrative Officer for the Riverside service area for Kaiser Permanente Medical Group, providing strategic oversight for that group, more than 700 physicians and 2,500 plus ancillary staff. They have over 500,000 plus Kaiser Health Plan members and families throughout Riverside. And prior to that, Bob has been in South Bay and other areas. Very lucky to have him here to share with us some of the insights from Kaiser today. Next slide, please. A little bit of housekeeping. So just so you all are aware, there is a Q&A feature in Zoom, and you can enter your questions there. You can also do it through the chat box if you'd like. We'll collect all those, and we'll answer them at the end if there's time. If there's not time to answer questions during the actual Zoom meeting, we send all of the questions out afterwards with written answers. So no worries if we don't get to answer them live. We actually received some questions in advance as well, so we're excited about the interest. In addition to getting the Q&A back written, everyone on the webinar will also receive a PDF of the PowerPoint itself and a link to the recording. So you'll get all three of those things afterwards. Finally, after the Zoom, you'll get a brief survey. We'd really appreciate if you can fill that out for us just so we can understand how we're doing. So that's it for housekeeping. Next slide. So today, the agenda, we're going to talk briefly about some of the trends and drivers of telehealth and how COVID-19 is one of the big market drivers for that. We'll talk about physician and patient adoption, operational considerations. Bob's going to talk about Kaiser Permanente, some really, really interesting lessons learned there at scale. And then we'll have, again, if we have time, Q&A. Next slide. So let's talk a little bit about the trends and drivers. It goes without saying that COVID-19 has been such a massive market change agent all by itself in terms of the impacts of the coronavirus epidemic. So there has been, we bucketed these into three main areas with relation to telehealth for folks to think about. One is the regulatory response, which has been rapid and consistent, a bit of a patchwork. Market and utilization trends, what are we seeing happening now 6 or so months in, and not sure how much longer this is going to last without a vaccine or herd immunity. And then also the impact on the continued transition to value-based payment, which has been an interesting wrinkle in this. So we'll start off with regulatory. So there are a whole patchwork now of waivers and relief bills that have helped providers to get paid for telehealth, which is great. We certainly are expecting more permanent reform down the road. One of the things that's important to remember is that even with the temporary relief, it's not perfect. We have gaps. One of the biggest gaps that we all talk about, which is really unfortunate, is the lack of the ability to do telephonic visits, for instance, with elderly patients that can't use a video app or video interface very well. So we know there are some gaps and challenges, and we're aware that that's part of what's slowing this down. In terms of market and utilization trends, it's just interesting to keep in mind as we think about how telehealth fits into the care model. So there's been a lot of regional variation. It goes without saying that there's been regional variation and impacts from coronavirus. New York City, for instance, got hit extremely hard. And at that time, there weren't the types of lessons learned for other folks in the country that got hit later with relation to proning your patients, the types of medicines to use, how to use ventilators. And so there was a lot of learning in New York City, in addition to the fact that there were high rates early on that helped other communities that got hit later. It does appear overall, if you look across the country, that most acute care hospitals and health systems are back to a good chunk of their previous utilization. But at the same time, if you're not a health plan, that is still a big chunk of revenue that's missing, and so may or may not be solved through cuts and furloughs and other types of things that folks have tried to put into place. We're still seeing a significant reduction in emergency department utilization nationally, anywhere from 25% off or more, again, depending on the community. We're certainly seeing increased telehealth activity, and in most places, not necessarily a return yet to pre-COVID levels of in-person utilization of ambulatory. And we're starting to see an expand use to home-based monitoring, hospital at home, other types of remote care. Again, payments not quite catching up. There are lots of interesting issues to be figured out, like who gets the savings. So one thing to think about as we go through this, talking about market and utilization trends, and then the transition to value-based payment, is savings and ROI really depends on your perspective and where you are in the value food chain, whether you're the payer, what type of business it is, whether it's PACE or whether it's Medicare Advantage or Medicaid managed care or fee-for-service. So it's not a straight line to an answer as to what the value proposition is for you with telehealth. We are certainly seeing this ongoing move to value-based payment. Many providers, meaning physician groups in particular across the country, saw their peers that were capitated do much better, of course, during COVID, because if you are getting premium dollar fed to you per member per month in advance, and you don't have to have it paid out for utilization, that's a nice temporary win, maybe a long-term win, depending where utilization goes in the future. Hospitals are not necessarily running toward value-based payment any faster than they were, although what we are seeing is that they at least want to make sure they have a solution for it. They know it's coming. It feels like there's a little bit more pressure and a feeling of the need to really understand how to be successful, but not necessarily jump into those contracts today if we can get our fee-for-service and get it at a good rate. And so those are some of the things that we're seeing nationally. Again, physician groups and IPAs being a little more aggressive, chasing after the risk because they don't have those hospitals to have to fill. So next slide. So some just thoughts before we jump into the group in terms of integrating telehealth into the care model. We talked about chunking this out into physician and patient adoption, which is really important. We always, with any new technology or care model, it's got to be easy for doctors to use, for nurses and other staff, and for patients to use, of course. And of course, not all patients and not all providers are the same. The operational considerations, there are many. We won't get through them all today. And again, really, there are some great lessons learned from places like Kaiser, Even though Kaiser is unique in that it has the plan, the hospitals, and the medical groups all heavily aligned, there's a lot there that's translatable to other folks nationally as we're thinking about how to move to the next level. So we've talked about the fact that it's really got to be, we said, easy to adopt, and we have to have incentives in place, whether it's for patients and families or whether it's for providers. So we got to make it easy, and we've got to make it pay, because people do what you pay them to do. We also have to think about this across the entire care continuum. It doesn't make sense to box this into one part, but instead to really think of this more holistically as we work through it. Another key consideration is really, how does this impact your workflows and staffing? It goes without saying that also reimbursement, and of course, finally, regulatory requirements. And again, Bob will spend some time walking through Kaiser, which I think will really be exciting for folks. So without further ado, I'm going to hand it over to Dr. Andy Snyder to kick it off. Andy?
All right, thank you, Alan, and good afternoon, everyone. Thanks for joining us. To talk about the physician and patient adoption components of telehealth in a broad sense, let's go to the next slide. We have to sort of link it to the business model and the care model have to go together, and the operating models, right? So if we take a step back, so managed care in all of its forms continues to drive towards value, as Alan was saying. But the structure and the math of all current contractual arrangements just truly don't support the required infrastructures and needed changes, and adequately incent primary care docs for the huge changes that they need to incur in order for them to deliver that higher value, more efficient care. So therefore, these advanced payment models in any form are gateways, but they're gateways towards full capitation. And until that level of risk is reached, it's really been hard to grow under this current value equation. However, COVID has proven one thing. Providers and organizations who've been under risk, and especially under capitation, have fared far better during these times when that normal supply chain of healthcare was halted. But even so, we seem stalled, right? That foot in each canoe persists as we look at the horizon. We're stalled in these advanced payment models with shared savings that no one seems to win enough adequately to grow. We're stalled in infrastructure to support true value-based delivery, requiring capital. Those capital dollars were meant to be derived from new value creation. Well, that's a catch-22. We're stalled in care model transformation. The physicians, providers of all types remain constrained. They're constrained working on transactional systems. These are meant to optimize and provide care and on documentation and coding, driving siloed episodic care. Providers also remain mostly in fee-for-service reimbursements for the majority of their business, even in all these APMs, perhaps with modest incentives for value. And that includes all these PPO, ACO concepts, and the like. So this hardly fosters innovation at the actual delivery level. So therefore, true efficient tools, the tools for value-based delivery across the continuum actually don't exist yet. But the technology does exist. But we have thus far failed. We've failed in aligning the capitated premium dollar completely through to the point of service. And whatever level that breaks down occurs, and whatever kind of contractual arrangement, wherever that breakdown occurs, the rest of the downstream delivery just reverts accordingly. So I can get off that soapbox now and return to the topic at hand, which is telehealth. I believe that if we achieve full alignment properly, the actual delivery of care would organically transform. Episodic care would be just that, right? It would be when an acute event happens. But healthcare would be much more longitudinal in nature. Instead of episodic histories and problem solving and tune-ups, care would be regular, right? Based on continual communication. So telehealth in its broadest case represents the gateway to a value-based system. Care would be a text check-in here, an email question there, trended home monitoring data going on, phone call discussions, virtual checks, and in person as needed by preference or need. But these would happen across the entire care team easily. And that would allow us to realize the promises of value-based care. Easier access, larger panel management, team-based care, efficient and engaging care, continuity and longitudinal care that improves quality. So as I wrote here on the bottom, full capitation allows episodic care to evolve towards communicative longitudinal care. So I know what you're thinking. You're probably like, when is he going to get off this damn first slide? So now, next slide, please. So for many reasons, telehealth has never really been adopted widely. Technology has advanced rapidly. However, adequate reimbursement has been lacking. But then COVID proved another lesson. Under emergency declaration, telehealth visits are temporarily reimbursed at the same rates as in-person visits. And out of necessity comes alignment in a fee-for-service world. And as you see, incredible uptake in use. So imagine if we properly aligned this use case for optimal use under capitation. Next slide, please. So for all the above evolving pieces, telehealth today is often program-based, right? Those on the left. Niche services that have been able to be commoditized for piecemeal reimbursement, for fee-for-service. They've been able to sell a siloed product. However, if properly financially aligned, telehealth would become what it should be. Not a program about itself, but simply a medium of communication, a tool. After all, I FaceTimed with my mom last night, and I texted her this morning. This isn't that complicated for most, albeit there are some gaps, but there's a long way of uptake that can be done. And patients increasingly desire the options and convenience. So can we get ourselves aligned and ready, and is really the question. Funds flow and reimbursement alignment begets this organic care delivery transformation and innovation. Next slide, please. The goals for all of us haven't changed on all sides of the equation. We all strive for increased quality, outcomes, efficiency, access. We have a disruptive technology at our doorstep. It must be integrated in manners that do not disrupt actual care delivery, but hold the promise to improve it. Next slide, please. So everything on this slide, I've touched upon all of this. But telehealth in all of its modalities are simply communication vehicles, right? Each has its own use cases. Texts for immediate, unplanned, short, quick. Emails for question and lengthy, instructive responses, but asynchronous only. Telephone's useful and underutilized with synchronous advice. Virtual, right? You can see rashes, wounds, many other signs and symptoms, movement. But just seeing a face and expressions is often as meaningful as anything else. You know, I mean, who doesn't like a good Zoom these days, right? No, but seriously, it must be easy, seamless, linked to this longitudinal documentation and informational shared platforms. And all of that comprehensively isn't in place yet. Next slide, please. So I think those that are truly willing to pilot compensation reform and align finally from the premium to delivery through capitation may allow for many of these operational changes. So can we optimize telehealth into our care model, operational model, and business model simultaneously? And it must be all three at the same time. So on that note, I'm going to hand it over to Rhonda to talk about some of those operational considerations. Thank you.
Thanks, Andy. It is a pleasure to be with everyone today. You can go on to the next slide. So we're going to talk about the process operations considerations. And, you know, before COVID, we really were kind of dipping our toe into the telehealth/RPM pool per se. And now we've seen with COVID how telehealth models have really emerged across the care continuum in both the acute, post-acute hospital, SNF at home are gaining some traction, and it's spreading across all settings. Telemedicine visits and consults are being used at home. Nursing homes, ER visits, especially when it comes to behavioral health, are now including remote patient monitoring as well. And, you know, RPM comes in many shapes and sizes. You know, diabetics have continuous blood glucose monitors now. Our high-risk patients that, you know, whether it's for readmissions or multiple ER visits, in some cases have active monitoring, which would include weight, they're taking their oxygen saturations and vital signs, and even now other opportunities for passive monitoring where it's connected by Bluetooth and will actually every 5 minutes send, you know, heart rate, respiration, you know, so that it can be monitored. All of this ultimately is to tie the patient to the provider as often as needed and as appropriate. Now, some of the challenges that, you know, Andy talked about and that we face: current physical space, technology systems, payment models, all support these silos. You know, I try to imagine a world where waiting for a bed on another floor or waiting for a bed in another facility is immaterial. You know, current transitions in care practices, we'll have to really carefully engineer and re-engineer to make sure we can navigate between the different programs, platforms, and levels of care. But if we're deliberate and we consider everything very, very carefully, it would be ideal if we could get them to actually be a straight line and all of these systems talk to each other. You can go to the next slide. Our opportunities and risk that we want to keep in mind as we move forward to deliberate telehealth is one of the best opportunities, as always, decreased cost in care, the decrease in delay between settings, increase in access to care for those individuals that don't have family support or that may not actually be able to drive or make it to their appointments. You know, we've found during the COVID emergency that we've transitioned and implemented very, very quickly. I think we probably are going to find that a lot of the risks are unknown because of the speed to market that I'm proud of, because we've been able to take care of so many individuals this way, but we're going to need to take a look back and go step by step. The risk mitigation is not necessarily going to be that different than it would be when you look at the categories and what you want to pay attention to. Patient safety, verification of provider and staff competence, making sure that you're protecting your technology integrity, and especially with how we respond in all of the disasters that we're currently faced with, between the fires and the hurricanes, thinking through, you know, if you're a nurse now in someone's home taking care of them, what would we do if certain things were to happen during that time? Other things that we might be missing that we'll need to plan for is there won't be that initial face-to-face when someone walks into the emergency room lobby and there is someone there to triage and check them in and do their screenings. There will need to be some risk mitigation put in place when it comes to that type of assessment and making sure that the patients are safe. You can go to the next slide. Ultimately, and I've felt this way throughout my entire nursing career, the best way to keep everybody safe is to really plan your operational steps very, very carefully. Ultimately, people, process, and technology. From a people standpoint, we want to make sure that we've got the right patient population that's eligible to participate in whatever telehealth program that you're putting together. Make sure that the staff is competent and that they understand the risks, they understand the patient population, they know the disease process as well. From a process perspective, make sure that the documentation is complete, that your policies and procedures guide and help those individuals that would be either at home or outside of a hospital geography, so that they know what to do in what situation, and if they are unsure, they have some place to look and get support. Technology, making sure that the monitoring of patients is appropriate and built individually for the right age, the right disease process, etc. Making sure that you're monitoring quality. What quality measures do you want to watch? What do we want to say is making our program successful? Making sure also the billing accuracy. One of the difficult things I think we know without a shadow of a doubt will be the appropriate documentation and billing, and navigating how are we going to make sure that we have all of the documentation appropriate for all of these different models in order to get paid for it. I think the other big thing we've discussed as far as the operational considerations is really making sure that you use a multidisciplinary group of individuals. Those people who are licensed, use them at the top of their license. Make sure that you're employing multidisciplines. We want to make sure that even if the patient's in the home or outside of the facility, they still get the right care and at the right time, even though they're at home. All right, you can go to the next slide. As we look at scaling, one of the things as we want to move the healthcare industry towards taking better care of our communities in safer places and at home, scaling is going to be difficult, and one of those things where we'll really have to consider carefully the reimbursement model and the care model. We'll have to make sure that the need, where is the need? What communities actually are realistic for this to be successful? And who are the best partners to help reach the goal and care for the identified patients? I think it will be very important to have diverse types of payment models that will enable the care model best practice. Just like Andy was saying, many of the providers and facilities that were under capitation or had value-based care contracts have fared a little bit better during COVID than those who were strict fee-for-service if their number of visits had gone down. Ultimately, really managing network and make sure that you've got the right technology partners, the right hospital system partners, not forgetting that there's access to home resources through your emergency technologists, your paramedics, IT support, sitter programs. With those wraparounds, this could really be a very successful program. So we're honored today to have Bob Blair here. I'm very excited to hear his case study from Kaiser Permanente. So Bob, I'll hand it over to you.
Thank you. Enjoyed listening to both of you guys and appreciate the opportunity to be here. I think I might start by just as part of it, or I don't know how many you all know about Kaiser Permanente, but often when I'm on a panel like this, in the past, I think it almost, the audience feels like, well, that's kind of alien to me, it's different. And I would make the case to you today that we are no longer different. We are very much collegial neighbors. And I think the world is changing quickly, and all of us need to really be thinking about how can we learn from each other and move this work faster. It's fascinating to me, and I'll talk about that a little bit later in terms of the pace of change that's happening in our country, and it feels too slow to me for many reasons. But I'm here today to highlight, and go to the next slide, to really highlight, this isn't a case study about comprehensive Kaiser Permanente programs around telehealth, but I've pulled out three areas of focus or examples of telehealth programs at Kaiser Permanente, and I'll highlight each, and then we'll talk a little bit about the implications or the ramifications of each of these areas of focus. The first one is what we call AMCA, Advanced Medical Care at home, advanced medical care at home, which really is hospital at home. And to give you an appreciation of really what that is, we have patients that need to be hospitalized. They meet interqual criteria, and yet perhaps they could get that care at home equally to how that might happen at the hospital, but there's so many reasons why it would be better for them to be home. They're more mobile. They're avoiding the risk of being infected by others. They're more comfortable in the home environment. And so we've begun this program 3-4 years ago. And today we have about 500 patients a year that we admit to home with a diagnosis that otherwise we would have admitted them to the hospital. You can see here that an example of some of those conditions that we might admit people home with are things like cellulitis. I could give you other examples if you're interested, but we basically identify a patient in the emergency department or in other settings where the hospitalist says, gosh, you know, you probably could go home, and we introduce that concept to the patient. If the patient's agreeable and if it's sounds like a plan that'll work, the home is a good environment to be able to do this in. There's some criteria. The patient has to be under 60. The patient has to not require monitoring. The patient needs to have a safe home environment. Assuming we meet these criteria, the patient has home health access, we admit the patient home. The patient goes home with a medical care program from the docs, with the nursing staff, and the doc will see the patient once. The nurses will see the patient daily, and we have had just tremendous experience in a positive way with this. We've had no safety issues. Patients love it. We find that our patients stay more mobile. They're healthier at home. So the patients that qualify and are admitted at home have really, really good outcomes. And so we continue to kind of strengthen this program. And we can talk about a little bit later about that criteria, because I'm going to challenge us and say, gosh, we could go so much further with this, but for a number of reasons, I think in our country, and because of so many things about our healthcare system, we don't move as fast as we might if we weren't held back by some of these things that we're challenged with. The second program I would highlight to you is called is just one aspect of remote patient monitoring. And there are other examples of remote patient monitoring at Kaiser Permanente, but the one I'm going to specifically talk about came out of this COVID crisis. You know, during the worst moments of our surge, we were at a point where our hospital beds were really compromised. Our ICUs were full. Our vents got to the point where we were concerned about whether we would have enough vents. We were having problems staffing our hospital. And meanwhile, the COVID positive rate in the community was going up just incredibly. And Alan mentioned that we take care of 500,000 members here in Riverside. It was pretty scary looking at those trends and hypothesizing how many patients we could potentially have in our hospital. So we started this remote monitoring program where, again, patients that met certain criteria could be discharged home and we could monitor them remotely. So patients, there's criteria. It's patients with a pulse ox above a certain level. They're COVID positive, they're symptomatic, but they don't necessarily, we didn't think, have to be in the hospital if we could monitor them remotely. So we sent the patients home on a Trappola MCare platform. They had a thermometer and a pulse ox at home. Once a day, that patient would report back to us their temperature, their pulse ox, some other information. We have a patient survey they take. And for the most part, the majority of those patients over 14 days, 7 to 14 days, they'd enroll in the program. They would have access to a nurse by phone 24 hours a day. They'd be able to get the care they needed. Some people would get sicker and have to come back to the hospital and be admitted, but the majority of patients got better. They were at home, they were healthier, happier, and they felt a level of confidence that the care they were getting really was very good. And then we had a level of confidence that we were able to monitor them clinically and keep them out of the hospital, which helped us to really manage this pandemic and this surge in ways that we might not otherwise have been as successful. We would have had to really stretch to admit all these people into the hospital. So we typically in that program have we still have, I think today, about 40 patients on that service. They come on and they go off, but we've had between 40 and 70 patients at a time that are active participants in that program. They're enrolled, they agree to be part of that program, like Hospital at Home. So we'll talk more about that, but patients actually do this because they feel, hey, this sounds good. I want to do this. I want to be part of this patient monitoring program, and I think it would be better for me than being admitted to the hospital. The third program that I'm going to talk a little bit about is just a broader ambulatory care, virtual care program or telehealth program that we've had in place for many, many years. So pre-COVID, probably 20% of all our ambulatory care visits in primary care and specialty care were telephone visits. We had started to do video visits too, but video visits hadn't expanded a whole lot, and probably 20% of our total visits, 15% of our total visits, 20% in primary care, maybe 10% in specialty care pre-COVID were what we called virtual, and the vast majority of them were telephone visits. And it's interesting, you know, Alan and Andy talked about how dramatic the impact of COVID has been on how we look at virtual care, because all of a sudden, you know, I think we talk about why we can't do things, all the barriers, and we'll talk about those as we get into some of these other slides, but we talk about all the reasons we can't do this, but boy, a pandemic comes along and all of a sudden we can do a lot more than we ever thought we could. Immediately when the pandemic began, and fortunately we had this wonderful infrastructure and platform in place, our virtual care expanded in ambulatory care to about 90% of our visits became virtual. So everyone went to telephone or video visits, mostly telephone initially. But if you think about why that was, from a patient care standpoint, patients didn't feel safe coming in. So all of a sudden our patients embraced virtual care like never before. Physicians and nurses, you know, have really struggled to embrace virtual care, especially video, but even telephone. And so when the pandemic hit, I think our providers, our nursing staff, really embraced virtual care because for them it was safe and it was a way to provide care. Even after, you know, today we're at about 60% of our total visits continue to be virtual. The change, there's been a big change because we've begun to move more aggressively into the video realm, because for a number of reasons, and I'll talk about that briefly. But if you look at that shift from 15% before COVID to 60% after, and we envision a world now where maybe 40 to 60% of our total visits will continue to be virtual. And so we've really had to ramp up how well we are able to do that. Go ahead and switch to the next slide. So as we talk about all three of these programs, one of the things that I think is really important to just mention is how important physician buy-in and staff buy-in are to the success of these programs. You know, we've really, I work for a medical group. I'm part of a for-profit partnership, Permanente Medical Group. In my case, it's the Southern California Permanente Medical Group, but it is pivotal and critical that our doctors own and feel responsible and as architects of these programs that we build, these changes in the way we deliver care. So I would say from the inception of any of these programs, our doctors are involved and participate in building that program and defining its success. So the staffing structure becomes critical. In the case of AMCA, you can see on this slide, we started with, it was really built by our hospitalists, and you know, it was built because the hospitalists saw value from a quality perspective in how people could go home and be admitted and get better care, have better outcomes, and after they were done, be in better health. But it also was going to be positive for the organization. It was going to save cost. It was going to allow us to have more beds for other patients. So it was a mutually beneficial program, but the structure that we built around it started with our hospitalists, eventually became our continuing care doctors who did this, and then there became a team of nurses and home health team nurses that helped manage this program. The training and socialization obviously is key, and in all of these programs, having the infrastructure, staffing, the workflows in place, and then really making sure that staff, physicians, and even patients had the training or the awareness, or we could socialize them in a way that we got buy-in as we went along, was critical, and particularly for our physicians. One of the things that I often talk about is how if we're going to be successful in any workflow, we have to make it easy to do the right thing. We have to make it easy for the physician to go that direction and do what we think is the right thing as a medical group. Even if I have a physician leader that wants to go that route, if it's not easy for the frontline doctor to do what we want them to do, or the nurse, we're not going to be successful. So we spend a lot of time trying to make those workflows easy and natural. Relative to Epic, for example, is it more clicks? Is it less clicks? Can we really optimize that experience for the doctor? And then finally, as we talk about the workflow, it really is important in our business to make sure that workflow design is well thought through, so that at the end of the day, our patients have a consistent experience. We make sure that they're going to get quality care, and that workflow is going to be something that we can replicate and train people so that they know what to expect, they know how it's going to work. We can build the systems electronically and otherwise so that workflow is successful. Next slide. So from a patient standpoint, I think the most important thing that we have come to realize is that if we're going to be successful with telehealth or with virtual care, patients have to embrace it. And from that standpoint, the COVID pandemic has been a blessing in the sense that patients have really begun to embrace virtual care and become more open to it than ever before. But what we have learned is that patient satisfaction with a virtual visit, or meeting the patient where they expect us to meet them. In other words, if we try to force a telephone visit or force a video visit on a patient, we're finding that is not successful. So I think one of our challenges has been how do we be agile enough to adjust the options that we're giving to our patients and socialize this as we go along in a way that patients are really happy, satisfied, and willing to take an alternative kind of a visit, like a telephone visit or video visit. In the midst of the pandemic, when we first started, everyone wanted a telephone visit or a video visit. As we come out of this pandemic, some patients really feel they need to come in, they need to be seen. Sometimes doctors have become so good at doing video visits or telephone visits, and they're more and more comfortable with that technology for certain kinds of patients and conditions, that they're feeling like, hey, I can do this as a video visit. But it's important that the doctor, the patient, and the system all align, and that patients can embrace with confidence that video visit or that telephone visit. So I think patient satisfaction becomes critical. How we identify patients and how we enroll them too becomes very important. In our case, often patients for the hospital at home program are coming through the emergency department. But all three of these things that I've talked to you about can happen through a telephone visit or a video visit. Not so much hospital at home, but especially remote monitoring or other types of video or telehealth care. So education and outreach of our patients is important. Patients learn about these evolving, emerging systems online. They're seeing these in terms of our advertising. They're hearing about them word of mouth. They learn about them from their doctors as they're having visits with them. And probably one of the things that we didn't anticipate as much before this pandemic, and especially as we shifted to video, is how critical the tech support was going to be. So those of you who have kind of dabbled in this a little bit probably appreciate that one of the hardest things about this is technology on the patient side and having everything work right. So we've started to do tech checks. Ideally on 100% of our video visits, we'll have somebody call ahead and make sure that the patient technology will work, that the patient understands how they're going to log into their visit. And we've done a lot of training with our staff and doctors, and that's a work in progress, and it's taken an intense amount of work and focus to become better at how we prepare for these visits proactively, and even how we train our team to support these visits. Next slide. So as we think about scaling, and I'm going to go through these last few slides quickly so we can get to questions, but as you think about operational considerations, it reminds me of a time when I spent a little bit of time at Harvard with, there was a professor named Clay Christensen. And if none of you have read his books, I think about, this was back in 2011, 2012, and he wrote a book titled The Innovator's Prescription for Healthcare in America. I think it's just called The Innovator's Prescription, but all those years ago, he imagined a world where we would be taking care of people at home. And I'm disappointed that we're moving so slowly, but this is a little bit why. As you start to think about, Andy talked about, how do we measure this? What are the metrics that are going to define our success? One of the things we've found is that we have good metrics on quality and on service, but it is very difficult in a virtual world to close those care gaps and to get those patients to do the things they need to do that we otherwise used to do when they came in for care and they were physically here. And so we've seen a really significant challenge now in a much more virtual world with being able to get patients to get the testing they need to do the things they need to do to take care of their health. It's the platforms are not ideal, and we're having to really think about those platforms and make them simpler, make them better, and cost becomes an issue. I think everybody thinks virtual care is cheaper. I'm afraid I don't see it that way. I think virtual care in some cases might be more expensive. So we might not move to a virtual world for cost alone. It certainly is more convenient for patients and sometimes for our teams, but it can be, as costly given some of the challenges, at least upfront, to socializing it and getting it out there. And then I think we all struggle with, if we're going to go virtual, are we going to get paid for virtual? And that's been a real part of the reason I think Kaiser Permanente has moved slower, because the federal government hasn't been willing to recognize video care until very recently, and still doesn't really acknowledge or recognize telephone care to the extent that we wish they did. And so I think reimbursement is a barrier. And then just workforce, people being comfortable with this, having the skills necessary, and then having the systems and the smoothness of those systems to make it work. Next slide. So future success, as we think about how we're going to be successful, we talked about this, the panelists. I think it's interesting. We're moving slower than I think it would be ideal. There's, even here at Kaiser Permanente, I think people think we move it easier, but everything is still siloed. When I think about remote care and telehealth, video visits, telephone appointments, hospital at home, there's not one umbrella for these programs and this migration. We still work out of our existing silos. So we've got remote care in various silos in our organization, and they're not connected. We've got virtual care doesn't necessarily fit into a nice umbrella because we're organized in umbrellas that we've had in place for decades. Patient choice and satisfaction is going to be key. This is really going to be about, does the patient get what they need, and do they have the confidence in the system based on that type of visit and what they're able to get, to get taken care of in terms of their health. Government reimbursement, I mentioned that, and then really getting our team on board. It has been a real challenge leading up to COVID to really socialize and get everybody on board. And now, COVID has helped us move people along, but there's still a lot of opportunity and work that we need to do to help our doctors and our staff to really embrace and feel comfortable, for example, with video visits. There's a lot of issues that have come up with how people feel about a video visit and being at home in their home and being able to see a patient. You no longer have a doctor and a nurse in a room. You have a doctor and a patient on a video link, all kinds of new challenges that come up as a result of those changes. Next slide. And so, I hope that was a good overview. We hope to get into some questions. I'm going to turn the time back over to Alan, and I look forward to questions you might have. There's so much we could have all said and just have limited time. So thank you, guys.
Thank you so much, Bob. So let's go to the next slide and we'll wrap up and get to Q&A. So the key takeaways we want you all to think about, again, a lot of this, of course, is meant to just be a little bit repetitive, nail it down. So we know we need reimbursement reform. We know that we can't always wait for it. So there's that balance, of course, of where do you just go and get things done for patient safety and access versus where can you get paid, and different payers, where can you negotiate payment for certain populations as opposed to others, just to get things moving. So one key thing to keep in mind is you won't be able to wait for it, but we know it needs to happen. Again, that return on investment and cost savings, what's really important to remember there is you just have to look at your particular perspective. If you're a PACE program, it's a very, very different return on investment conversation than if you are a PCP practice without PCP cap, than if you are some kind of a capitated entity at the professional or even institutional or greater level, or if you're a payer for Medicare Advantage, Medicaid managed care, commercial, et cetera. It really does depend on where you are. So there are no sweeping generalizations we can make about how return on investment or cost savings will work for you. Everyone has to understand their own situation. Again, we talked about the need to integrate across the care continuum. It's so important. And to make it easy to use, which means talking to your patients, Bob's point about doing those tech checks before the calls every time or before the videos every time, it's really important that people, of course, can actually use these things. Otherwise, they're just interesting. And finally, as Andy and everyone said, it's going to grow. It's going to play a larger role. And, to Rhonda's point, the whole integration into operations is so important. So making sure that this is integrated into your care model as well as your reimbursement, and really thinking about how you're going to be able to be flexible and scalable for the future, because I also think Rhonda really did a good job pointing out that there are different types of events that are going to be happening. It's not just COVID. And so what's really important is to have a care model that has different types of decision pathways based on what you're dealing with. So that's a quick overview. We're going to flip into Q&A. And so I'm going to actually ask Bob the first question. So Bob, my question for you that came in from the group is, how do we really address the underserved barriers with 5-speed 5G connectivity? Different communities, of course, have different levels of access to the internet, and it's such a foundational issue. The question continues that these solutions won't go anywhere if connectivity isn't solved. So, Bob, do you have any thoughts on that really kind of challenging conundrum?
So I think it's a challenge. I can't say that we've nailed it down, but I would say we all need to move forward and we need to figure this out together. As you talk about platforms, it's fascinating how the stereotypes we have, or the things that we believe about either the elderly population or the poor population in terms of access. And some of them are true and some of them are not. It's interesting. People have cell phones. They somehow get access to networks. And whether they're older or whether they're less affluent, I'm not always sure that that's the barrier. Sometimes it's just which network they're on and whether that network has problems. But we've certainly been challenged with that's why we do these tech checks, So before a visit, especially a video visit, we'll call a patient and make sure everything works. We're much more successful by doing that than when we started. When we started doing video visits and we didn't have tech checks, often 50% of the time the doctor would get on the phone, it wouldn't work, and the doctor would immediately shift to a phone visit because it was easier. It was easy to do that thing than it was to try to pursue getting that video visit to work. But the tech checks have increased our success with video visits exponentially, and that has been a costly investment to do a tech check that's pre-encounter, pre-visit. But I think it's interesting that most of our patients, it's not so much about that they don't have the technology. It's about the network, and it's about, in our county, for those of you who don't know, I'm in Riverside County in Southern California. It's a vast county. It's 22,000 square miles, and some of our patients that are out in the periphery, the network is not, it's not as reliable. And if you lose the network, you lose the video visit. And so I think the other thing that we've had to be able to do is be more agile and be able to quickly convert a visit from a video to a phone visit if for whatever reason the network doesn't work. Hope that answered your question, Alan.
That's fantastic, Bob. And what I'll just add is that another thing we've seen with relation to not just the geographic coverage, but also income levels. So when you've got folks like Medicaid and uninsured, and they may not have, for instance, any kind of Wi-Fi or connectivity just because they can't afford it, we've looked at, the issuance, for instance, of cell phone-enabled tablets or other types of options. There are all kinds of concerns. Are certain populations at risk for them being stolen or even sold? But there are, again, it's like everything else we've been talking about, different options and different solutions for different particular populations.
Maybe
Another question that came in.
Given what you just said, let me add one final thought on that. When I talk about a video visit, much of the time the video visit for the patient is on a phone or can be on a phone. So we are frequently using a telephone as that medium for the visit. And we've invested in giving each of our doctors a phone, an iPhone, that they all have. 100% of our doctors have an iPhone. The beauty in that is we control that network, we control the apps on that phone, and we can push, apps out and products out to the doctors that are very beneficial for the patients. But I definitely think, it's surprising how many patients, regardless of socioeconomic status or of age, have a video compliant or a video functional cell phone, and they often work pretty well.
That's a really, really good point. So again, so many, what I think this also brings to bear is it's so important to find out what the situation is uniquely for each patient. And I think that flows into this other question that just came in. I'm going to give this to you, Rhonda, because I know we're all doing a lot of work around social determinants of health and how to close some of those gaps. So this person's question is that there are, of course, perceived disparities that technology brings for certain patient segments, but at the same time, virtual health could potentially reduce some social determinants of health gaps like transportation, access, childcare, time away from work. What are your insights on that and your thinking around that, Rhonda, if that's a reasonable question to share with you?
Sure, absolutely. I know that some of the things that we've done in a program here in the southern part of the U.S. has been simply providing rides for those individuals who cannot make it to, if it's dialysis or if it's something where they truly cannot get to where they need to go. We've also had some of our primary care pediatricians have actually utilized ambulances and have started driving to their patient's home instead of making all of the kiddos come in to be seen. They were finding that nobody was coming in to be seen. And so they went to each of the homes, as well as there's actually a program with another pediatric individual here in the South that has a telemedicine set up with each of the independent school districts, to where if a child comes into the nurse's office sick, they actually have some kits and they call the parent and they're able to do a virtual visit right there with the school districts, which really does help catch those kiddos that may not have the ability to go see a regular primary care pediatrician.
Perfect. Thank you so much. And we'll wrap it up with a question for you, Andy. And again, a lot of these questions have similar threads, but how can we begin to move on this and not have technology be the barrier? What do we think can be done to move in the right direction and in terms of integrating goals? I think that part of the question here, Andy, is even financial incentive alignment and outcome alignment. So could you take a minute to speak to that?
Yeah, I mean that's where I would start. To me, it sort of goes back to the follow the money, right? And it's a funds flow, and if the funds flow is aligned, the physicians will want to use the modality that's most convenient between them and the patient that provides the best care. And that's what I mean by sort of changing that care model organically. It won't be forced. It'll be what aligns with, what there's an adage, the system is the outcome's exactly what the system was built for. And we have to build it right. Perfect.
Well, with that, we are right at the hour. I want to thank everyone so very much for their time today, for joining us. And as we said, we will get everyone the materials out as a follow-up. Thank you so much to our panelists, Bob, Rhonda, and Dr. Snyder, and also to our guests. So everyone stay safe. Have a great day. We're going to go ahead and sign off.